you. Welcome, everybody. We're just going to wait a couple of minutes as we get started. Bienvenidos a todos. Vamos a empezar en unos pocos minutos. Gracias por su paciencia. Thank you for being here. We'll get started in a couple of minutes. Thank you. Bienvenidos a todos. Welcome. We are going to get started in just a couple of minutes. We're allowing folks a little bit of time to transition in. Thank you for being with us in this session on cultural competency in healthcare services. Ahorita empezaremos. Welcome, welcome.
Bienvenidos, bienvenidos.
Gracias, Melina.
Oh, you can still hear me.
Oh yeah, you'll just have present yourself and as the interpreter, and then I'll move you into your room.
Got it. Okay, thank you.
Mariah, should we get officially started with the presentation and those slides?
Yes, let's do it.
Okay, let's do it. The next slide starts the interpretation instructions. Welcome, everybody, to the session on cultural competency in healthcare services. To access interpretation via your computer, please follow the instructions on the screen. There is an interpretation option, and you can pick the language that you would like to hear. And if you only want to hear the interpreted language, click mute original audio, and I'll hand it over to Melida.
Buenas tardes, bienvenidos. Yo soy su intérprete de español. Por favor, si quieren escuchar la interpretación en español, por favor, hagan clic en el globito que aparece en la parte de abajo de su pantalla para así poder escuchar la presentación en español. Muchísimas gracias.
Here's some instructions to do the same via your mobile phone.
Estas también son las instrucciones cómo hacerlo usando su teléfono móvil. Do you want me to read them, Ms. Álvarez?
Sure, why not? Just in case.
Sí. Señores, como pueden ver, estas son las instrucciones en español. Como pueden ver, el control de seminar se haga clic. Esto es cuando están usando su teléfono, su celular. Hacen clic en los tres puntitos. También hacen clic donde dice la interpretación. Escojan el idioma que quieren escuchar. Si solo quieren escuchar el lenguaje interpretado, tienen que hacer clic donde dice Mute Original Audio. Donde dice, y después hace clic donde dice Done, que quiere decir que ya terminamos. Gracias.
Gracias. Next slide, please. Okay, well, good afternoon. Buenas tardes, good afternoon, everybody. My name is Mayra Alvarez. My pronouns are she, her, hers, and I serve as president of the Children's Partnership. I'm excited to be here with you to talk about cultural competency in healthcare services, especially to better serve our families and children with special healthcare needs. I am here from the Children's Partnership. We're a statewide advocacy organization focused on advancing child health equity. And we do that work in partnership with state and local organizations. to advance policy, to do community-centered research, and to really focus on community partnerships and engagement. And we're proud to do that work alongside many organizations affiliated with the Family Voices Network. Next slide, please. As we talk about cultural competency, I want to ground us in some core beliefs that we have at our organization, really thinking about who we are advocating for when we seek to advance child health equity. We strongly believe that a child is a child, and that regardless of their race, ethnicity, or place of birth, all children have equal value and potential, and that all children really require each of us to work as hard as possible and to work together to expand resources and opportunities for their well-being. We also firmly believe that dismantling systemic racism is required for children to thrive. And that is something that you'll hear throughout our presentation today as we seek to advance cultural competency in healthcare. As part of that work, another core belief of ours that you'll hear come up throughout today's presentation is the role of community input in child advocacy and in our work to improve care delivery for children and families. We believe that communities know best the solutions to the challenges they face. And so we seek to work in partnership. We invite, we engage, and we design solutions with community members through our partners in order to ensure that we're accurately addressing the needs that communities have identified. Along those same lines, we believe we are stronger when we work together. And so our work is intersectional. We know that families do not lead single issue lives. No family can worry about their child's health today and then worry about paying rent tomorrow. Every day, families are grappling with multiple issues. And so we as advocates also have a responsibility to work in partnership to address those multiple issues. We also believe in effective partnerships and that those partnerships deserve time and effort to be as strong as possible, that they not be transactional, but that they be transformational, and that we are in community for a long period of time in order to create the systemic change we want to see. As part of that, we want to make sure we go back to community with what we hear, again, to discuss those solutions, and more importantly, to provide opportunities for change, for community to engage. And then finally, I want to say that we recognize that our priorities as advocates have to shift depending on what community needs. So our priorities will change as social conditions change. And these are themes that will come up throughout today's presentation as we think about cultural competency in care delivery. Next slide, please. As I head into this presentation, it is grounded in partnership with many organizations, again, that we were connected through Family Voices. Here is a snapshot of many of them. I want to acknowledge and appreciate their time and effort over the years. So just again, in the spirit of that partnership and valuing that partnership, I want to celebrate them and celebrate their leadership and their contributions to this work. So thank you. Next slide. So today's presentation, we're going to go over a bit about definitions around cultural competence in healthcare. We'll then talk a little bit about the intersection of cultural competence and in particular, care for children with special healthcare needs and why it matters that we advance these incredible values and goals as part of the care for children with special healthcare needs. I'll talk about some specific community-based research that we did, again, in partnership with many organizations that provide some really valuable lessons around what cultural competency means and how we move that work forward in the policymaking process, as well as care delivery itself. And then we'll talk about where we go from here together. What are the opportunities to move forward to promote this inclusivity and ultimately equity in healthcare delivery? And then, of course, we'll leave ample time for questions and answers and discussion to ensure that this time together creates community and hopefully opportunities for action as we move forward. So thank you very much. As we get started, I wanted to pause for a minute and get your thoughts on what is it that brought you to this session? Like, what do you want to get out of today's session? And Mariah, I'm not sure if folks can raise their hand or how it works, but I'd love to get some thoughts from people about why they're showing up today and what made them click on this box. And what questions do you have that you hope we will either cover today or that you'll have information that can help you learn more. So I want to pause and see if folks have any questions that come up for them or want to share what you hope to get out of today's session.
Perfect. They should be able to pop it in the chat, and then we'll be able to see the responses there.
Anybody can share what they're interested in and what brought them to this conversation. There's no right or wrong answer. The question is like, what brought you to this session? What made you interested in this topic? And are there any specific questions that come to mind for you that you either want answered or want more information? I appreciate that. Jessica and King Ellis says, I'm a Black mother who wants to give solutions as I hold providers and organizations accountable. Appreciate that. And Jasmine comes to the session to see what changes are coming, if any. There might be some frustration there, right? When we're not seeing the changes come soon enough for the families we serve or the families we're a part of. Marta says, working in a family resource center, we would like to learn more about cultural competence in the medical field. Absolutely. Gilda, thank you for sharing. She's a parent of a child with spina bifida, and I am part of the Hispanidad Spina Bifida Association Committee and part of the AAP ECHO. Interested. Great. Vanessa's a medical social worker and wants to gain more insight on resources. Excellent. Great. Well, again, I'm grateful to be in community with you and I'm excited to enter this conversation and believe we're constantly on a learning journey around how we can improve, how we care for children and families. So I hope this offers additional perspective and that we continue to learn together. So thank you very much. And thank you, Mariana, for lifting up the difficulties for non-English speaking people. That will definitely come up. Okay, so next slide, please. Okay, so I want to start with this slide because I want to ground us. I want to ground us in the reality of the why behind cultural competence. If we think about the conditions in which children are raised today, we recognize that there are a number of factors impacting their health and well-being. And the fact that children and families have access to medical providers is just one piece of what actually influences a child's well-being. Over the last few years in the state of California, there's been an incredible effort to elevate the impact of adverse childhood experiences. This idea that there are experiences that occur when we are children that have long-lasting impacts on our lives and that influence how healthy we are, how much we are able to contribute to society as we head into adulthood. I want to start there because it's important to consider just how influential these social drivers of health are for well-being. Because if you look at this tree, and this comes from Dr. Ellis in Washington, D.C., it really speaks to the multiple opportunities we have for intervention in order to improve child well-being. And when we talk about cultural competence and where cultural competence is trying to improve care for children and families, we have to consider these many factors that influence culture, that influence our environments. Everything from poverty, violence, racism and discrimination, community disruption, the lack of opportunity or upward mobility as a result of these other factors. And those also contribute to what we see on the surface, because oftentimes the poor housing quality or violence or discrimination may not be as apparent as we're serving families, but we do see substance abuse, or we do see homelessness or mental illness. And so how these factors manifest themselves in our children and families is particularly important as we're seeking for providers to better care for our children and families. This awareness of these external social factors and how they influence the well-being of a child is so important, and highlights how much of a root cause of child health inequities something like racism really is. And so I wanted to start us there to ground us in those experiences, ground us in that reality, to not think that racism is something that happened hundreds of years ago, but that it is something that is alive and well today. Many of you are probably like rolling your eyes and saying, duh, but oftentimes it gets missed and it's worth repeating. And I wanted to start us there and ground us in that. Next slide, please. So here is a snapshot of what we have named this session around cultural competence, and a snapshot of the definition of cultural humility. Cultural competence, and that as a term, has been around for decades. It's loosely defined as the ability to engage knowledgeably with people across various cultures. Again, it comes from decades ago, 1960s and 70s, and really became connected to healthcare from its inception. But in thinking about cultural competence, there are two challenges to that term. One, it almost implies that there is this level of knowledge that someone can attain about a group of people. Like, you are culturally competent, which can inadvertently or lead to stereotyping and bias. And it also, again, implies that there's this end point to becoming fully culturally competent, when we really know that that journey of learning around culture and understanding is ongoing and something that we have to commit to every day. So I'm offering this additional term around cultural humility that was introduced decades later as learning, and we evolve in our practices, again, in our healthcare system. It recognizes that there is a lifelong process that's focused on learning about others, but it's also focusing on learning about ourselves, on self-reflection, on our personal critiques, so that we can actually start to unpack some of our own biases as people, and most definitely as providers. And I think it also, what we have learned as these terms have evolved, that there's this recognition of what we talked about around our core beliefs, that we have intersecting identities. People are complex beings, and that there are intersecting identities. And we want to encourage curiosity rather than this endpoint that we will be culturally competent. That complexity of identities offers us the reality that we're never truly done in this learning journey. Additionally, cultural humility offers an opportunity to really open up conversation around identity, around race and ethnicity, around gender, sexual orientation, income, education status, any number of what someone identifies as, and really allows us to become better aware of what's happening around us. And then when I think about how we can make sure we distinguish between these terms of culturally competent and culturally humble, it goes beyond this knowledge and awareness of different beliefs and practices and values of diverse populations. But again, really speaks to that inward journey as individuals and people that is required to truly provide the most culturally responsive care for our children and our families. Again, this awareness of our own possible biases, in order to attempt to be non-judgmental about what we hear and ensure that we aren't presenting any sort of privileges as we're working with our families. The other concept I wanted to introduce to you all, and many of you may already know this, is the cultural iceberg. And this comes from Dr. Milton Bennett, and offers us even more to think about when we are working in diverse communities in order to be responsive to people. Again, this idea that we obviously know, or we have elements of culture around us. We think about the food people eat. We think about holiday celebrations and acknowledging different dances or literature or the language that people speak. That's very surface of culture, and what we often see as efforts to be open and welcoming. And they're important. They're important to acknowledge and create a welcoming space for children and families. But what we also want to acknowledge is that icebergs are often only partially seen on the surface of the water. So if you think of the massive iceberg underneath the water, there is so much more that contributes to culture. Communication style, norms around those communication styles, concepts and what they mean in particular cultures, attitudes towards certain populations, different notions of what terms mean and who is a leader, who is not. And so this idea of being able to constantly learn and reflect and grow in our understanding of culture is something to consider, and again, something to recognize that we're never truly done, and that we constantly have to be open to those opportunities to learn more. And so I hope this snapshots of definitions provide you some greater perspective on how we want to move from cultural competence to cultural humility, and that we are constantly on that learning journey as we seek to improve care for children and families. Next slide, please. So as we think about cultural competence and meeting the needs of our children, this slide really offers you a roadmap around what we want to do to better address those needs, both downstream, which is primary care, the care that we see between providers and children, but also midstream, thinking about what are health-related social needs, and upstream. And this stream analogy comes from public health and public health literature. So for those of you that are public health backgrounds, if you could bear with me for a moment, there's this idea that there's a river and there are babies floating down that river. Baby after baby are floating down that river. And so someone downriver is taking those babies out and saving them from the water. They're taking the rivers out and they're saving them from the water. Right? But someone realizes, doesn't it make sense to go upstream to learn why are babies in the river floating down the water? What is happening that those babies are floating down the river? And can we prevent them from being there in the first place? That's what we're talking about when we say we want to move upstream. We want to move in the direction that allows us to prevent illness, prevent more serious development of disease, this idea that we can intervene earlier in order to support the well-being of children and families. And I talk about this from a cultural competence and cultural humility perspective because of the need to view culture, to view addressing culture and acknowledging it and celebrating it as moving upstream in our care. Cultural humility, cultural competence can play out both upstream, midstream, and downstream. But it's critically important to really think about how, as we move upstream, we can incorporate this commitment to culture, this value of culture in our strategies working with children and families, as well in our tactics to ensure that care is as strong as possible. And this includes the conditions in which our children are raised, but also the laws and policies and regulations that create those conditions that ultimately impact the health of children and their families. Next slide, please. Oops, back to one more. Yeah, they're perfect. Thank you so much. And so this is, as we think about the work that we're doing with families, the work to be more culturally humble, more culturally competent, it's incredibly important to bring attention to community engagement. Oftentimes, as we think about culture and we think about what defines a culture, we think about the people that surround a child, the people that surround that family, whether it is their community, whether it is their ethnic community, their religious community, their geographic community. There's a number of ways in which we can define community that influences the culture one was raised in and one brings to the interaction with a medical provider or a social worker or an educator. Again, that enables us to be that much more responsive to the unique needs of that child or that family. The belief that community engagement and health equity go hand in hand rests in the belief that I mentioned at the beginning, the idea that those closest to the problem are closest to the solution, so that we can really tap into the incredible expertise and leadership of community to improve care delivery, to really think about how centering community leadership and community wisdom allows us to shift this power dynamic between the systems that are supposed to serve our children and families to the family themselves, to the community itself. And again, it's central to really understanding and responding to the population's needs, but also the population's strengths. These protective factors that culture brings for many families, for many children, particularly children of color, these protective factors that have enabled them to thrive, oftentimes in very challenging environments. And so when we think about families with children with special healthcare needs, their incredible resilience, their incredible commitment to their children, the love, the community that surrounds them, that is a protective factor of culture. That's an incredible strength, that if there's ways in which our healthcare system can tap into that power and strength, then we know we will be that much more prepared, that much stronger to care for the well-being of these children. And that's the goal as we seek to move our system to become more culturally responsive, more culturally competent, more culturally humble, and again, better caring for children and families. Next slide. So now we're going to move into this space between intersection of cultural competence and care for children with special healthcare needs. Next slide, please. Thank you. So I want to start with a few data points for you. So I think we all know this, that California's children are incredibly diverse, and in particular, children of color make up a significant portion of the state's population. So the idea that we require or need a more culturally competent system, it's not a nice to have. These are our families, and caring for these diverse families will enable us to improve care for everyone in California. So nearly 9 million children live in California, just over 9 million children live in California. 3 out of 4 of those children are Latine, Black, Asian American, or Native American. We know that we have an incredibly diverse community of children, and as a result of that, want to bring this attention to the need to create a stronger healthcare workforce, a stronger community workforce that reflects the diversity of these children and their families. Next slide, please. So connected to that is the fact that we know in California, the majority of children rely on the Medi-Cal program for coverage. We know that about 5.5 million children in Medi-Cal are children, 5.5 million children rely on Medi-Cal. That's over half of that 9 million children in the state. And again, this is overwhelmingly children of color. So Medi-Cal, it's a fundamental lifeline for the safety and well-being of our families. And for children with special healthcare needs, it is truly a lifeline in many instances. So again, with the diversity of our community, how do we ensure that that program is as strong as possible in order to meet the needs of this diverse population? Next slide, please. At the same time, as we think about this program and how we want to make sure it's as strong as possible, I just want to call attention to a few numbers that present the reality of how challenging the Medi-Cal program is for the state of California. And when we think about well child visits and the opportunity to care for our children early and often in order to identify any developmental delays, in order to ensure they're on the path to healthy childhood development, we are almost last. We are 48th in the nation when it comes to well child visits in the first 15 months. We are 43rd in the nation when it comes to developmental screenings. And we again are 48th in the nation when it comes to receiving needed mental health care. And this is despite the fact that a Medi-Cal program actually requires by law that children will receive all of the necessary services they need to be healthy through this early and periodic screening, diagnostic, and treatment benefit within Medi-Cal. The reality is that the program is not actually responding to the needs of families and not giving the attention that families need in order for their children to be as healthy as possible. Next slide, please. And I want to draw, again, paint a bit of a picture of who children with special health care needs are in the state. And this might be data that many of you all know much more intimately than I do. But I think it's important to bring attention to this, that nearly 1.3 million children in our state have special health care needs. And again, that the majority of them are children of color, so that these reflections of the Medi-Cal population, the population of children in our state, the population of children with special health care needs, these are all parallel. There are majority children of color, majority diverse communities. So we want to ensure that there's opportunities to respond to the needs of these diverse communities, because we know that if our programs, our systems serve these families, every child, regardless of background, is going to benefit from a stronger system. And so this is part of providing that snapshot and offering that there is more to do. Because if you think about, or if we review the literature, if we review what is happening around research and recommendations that can improve care for children with special health care needs, it's not robust when it comes to the specific experiences and challenges facing families of color. So again, drawing attention to these communities, drawing attention to the reality that these are our children, will only help move us in the direction of better serving these children and their families. And that's exactly what we're trying to do through these research efforts. Next slide, please. So I'm going to transition us into the lessons from these reports, because I want to make sure we get to questions and answers. And again, these reports really do seek to center families' expertise and experience. And for many of you that are here that are family members, you know exactly what I'm talking about. You are the expert on your child, and that's what's going to come out in these next few slides. Next slide. So the first report we did was really a look back at the pandemic and how it impacted children of color, particularly children of color that have special healthcare needs. And why we did this report was really grounded in that fact I just said, that when we looked at research of children with special healthcare needs, particularly those of color, there was not a lot of information that centered the voices of Black families, of Latina families, of Indigenous families. And so in particular with the pandemic, we wanted to draw attention to this incredibly marginalized community, because from a targeted universalism perspective, if we can improve care, if we can improve how systems respond to the needs of a marginalized community, we know that that system will better serve everybody. So why we did this report, we wanted to learn if telehealth was really increasing access to care. We wanted to learn directly from those families of color who have children with special healthcare needs. And most important, we wanted to make these recommendations to policymakers directly, and again, do so by centering the voices of these families. And a reminder of this as we went into this research, that our state ranks last in the country in the percentage of children with special healthcare needs whose families feel they have shared decision-making with their providers. So the only way to go is up. And how do we do that? Is through an informed, community-centered approach. Next slide. So this project was intentionally, again, designed to center the experiences, knowledge, and recommendations of families of color who have children with a range of special healthcare needs, particularly to develop a policy agenda. We partnered with multiple community-based organizations, especially the ones I mentioned earlier in the presentation, to recruit families of color in target regions whose children had special healthcare needs. And we used strategies that sought to share power with families and really make this research meaningful, inclusive, and adaptive to their needs and circumstances. In total, we recruited about 85 families of color to participate in 3 different regions: Pomona, Tulare, San Bernardino, and the San Bernardino Riverside area. And families that they self-identified their identity, and they ranged from Latina, Black, Native American, or Asian American. Over half of the families were monolingual Spanish speakers, and children were represented from all grades. And again, they had a range of unique healthcare needs that included physical, developmental, mental, and complex health conditions. And the learnings really do reflect the voices and experiences of these families. Next slide, please. So this is a snapshot of the learnings. And really, as you review this list, there's a need to consider how this theme of cultural competence, of cultural humility, can help better support better services for these families. Thinking about the need to improve how telehealth is responding to families, thinking about how having telehealth didn't do away with the additional challenges that families of children with special healthcare needs have regarding lack of transportation or wait times or childcare. Again, this idea that our challenges are intersectional. It also illuminated the need to see a doctor continued, right? That telehealth is a critical service, but that there is more to do when it comes to responding to the needs of families. And it illuminated the continued systemic challenges that are facing families, particularly those that were attempting to use telehealth, including the lack of technology, the lack of the digital equity infrastructure, language barriers, and again, these cultural barriers. And of course, that, if we reflect back on the pandemic, just how much instability continued for many families is the reality. And that came through loud and clear in what we took away from what families were saying. Next slide, please. So as we think about these digital, educational, cultural, and language challenges, the digital divide was alive and well, and this included like a lack of Wi-Fi or devices, really thinking about the lack of high-speed internet that limited then the ability to engage digitally with providers, but also the reality that that's connected to so many other aspects of life, whether it's education for a child or job connections for parents and caregivers, access to housing supports or nutrition supports. Oftentimes, so much is reliant on technology that without that digital infrastructure, you are then adding these additional barriers to families. Additionally, there was like insufficient information around how to take advantage of these services through telehealth. Just the process of it, we heard loud and clear from families the need to have some navigation support around utilizing these services, again, in language by someone that's trusted. Language barriers continued despite language access being a right for everyone. It was a reality that was not apparent for the families that we talked to. And then also just the reality that there was a lack of providers who look like them, who share the identities and experiences of the families that they serve. Next slide, please. So this is just a quick snapshot. I'm not going to read all of these, but just some quotes from the families that we wanted to uplift. A couple that really spoke to me was this idea of living in a zone where the Wi-Fi fails a lot, and that the school has given us internet devices that are not that great. So again, the frustration that families feel, the inadequacy that is placed upon them because of the systems that are failing them. Another parent shared how California Children's Services has never provided them a report in 25 years. And again, these experiences may vary from parent to parent, but what we heard was not feeling centered, was a feeling of dismissal, of not feeling valued by the very system that is supposed to center your child and you, and is supposed to be there for you. So what do we do with that information? So I want to pause here and again, try to see if I can get some audience interaction in this time together during the lunch hour, nonetheless. How do these experiences resonate with you all? Have you or your families experienced these types of challenges or barriers, whether it's Wi-Fi and digital equity, or accessing an interpreter and language access support, or even barriers accessing vital or important documents about your child's health? Let me pause there and see if anyone wants to share thoughts that have come up for them in listening to these reflections. Thank you, Marta. Marta says that these barriers resonate, and that one of the ways that they have helped is by providing trainings around technology and how to utilize them. Absolutely. As we look at the recommendations, that's going to come up for sure. And would love to hear more about that, Marta, as we continue this conversation. Okay, next slide, please, Mariah. So here's a snapshot of the recommendations that came to us from families, and that we went back to families to make sure this is what we heard from you. Is that right? Again, acknowledging that those closest to the challenges are closest to the solutions. We also asked families about these recommendations. Again, did it respond to what they were looking for? We also engaged in that research to expand upon families' recommendations so that we could move these recommendations forward. And so, one of the points that Marta just raised was this idea of providing trainings around technology. Well, one thing we heard loud and clear from families was this support for community health workers, or some sort of a community liaison, a promotora, that would enable some support around navigation of these incredibly complex systems. For many of you who have a child with special healthcare needs, You either had someone to walk you through it, or you yourself had to figure that piece out. And now you are bringing that expertise to others. You are paying that forward. How can we center that leadership, that wisdom, that lived experience, and allow our healthcare system to be stronger because of it? There's also, one of the recommendations was the need to have greater outreach, education, and resources to help families better understand telehealth in order to access these services. And again, telehealth was the example we used in this research, but it can really be applied to any service that is obtained through our healthcare system. Again, trying to be responsive to what families need. Another one was this idea of mental health services and the ability to be intersectional in our care, so that a family may be coming in to seek support for a very specific issue, but some mental health concerns arise. And how can we ensure that that trusted space connects families to the services that they need to be healthy holistically? So these recommendations really touch on many of the themes that people have talked about, and the complexity of care that we're looking to address as we're trying to become more culturally competent and more culturally humble. Next slide, please. So another project I want to touch on is what we've called our ETE project, which is equity through engagement. And this is, again, the idea that our Medi-Cal program can do better by the majority people of color it serves, and that connecting to community is key to making this possible. That connection and trust with community is a key factor in becoming more culturally competent, culturally humble, culturally responsive in the care we provide. And that piece really was around these two premises associated with this project. Next slide. So the goal of the project was to better understand families' experiences in Medi-Cal. And in particular, for our state of California, that really looks to managed care plans to offer this care for families. How can we see managed care plans as partners in addressing those social drivers of health, and in partnering with community-based organizations, with community leaders, again, to better address the child well-being and be responsive to families' needs. All of this within the idea that the state of California is in the middle of this incredible effort to improve our healthcare system, and in particular, the Medi-Cal program. So knowing how fundamental Medi-Cal is to the well-being of over 5.5 million children and families, many of the 1.3 million children with special healthcare needs, how can we strengthen that program as much as possible for these kids in particular? Next slide, please. So I want to bring us back to that first conversation around community engagement and child health equity, thinking about how Medi-Cal health plans can work to address these social drivers of health. I think these concepts of community and being community-centered and engaging community, they're not new to our healthcare system, but someone mentioned this earlier, the accountability factor is new. And the ability for us to say, we will not go back to a system that was not working for our children and families, is evolution. And there's an opportunity to hold those health plans, our health providers, more accountable to being responsive to the needs. And much of that centers on the relationship to community organizations. And that is part of the premise and part of the work that we try to do through this equity through engagement effort. So let me talk about that. Next slide, please. So we held a number of focus groups with families of color, again, to try to better understand how they were engaged with Medi-Cal. I will say, as a daughter of Mexican immigrants who still helps her parents in figuring out applications and has done that since I was little, it's still confusing. It's still difficult. And that is what we've heard from families across the education stream, across the income spectrum, but in particular for this population working with Medi-Cal, that there were these same challenges that came up, similar to what we heard in our other study around telehealth. This idea that maintaining that coverage is cumbersome, that there is this need for more holistic care, talking about us as whole beings, the confusion of the materials, the need for greater support, again, to walk us through these systems to help us better understand what's happening, and this lack of recognizing the incredible expertise and knowledge that parents and caregivers are bringing to the space, that parents have not been recognized as the experts in their children's condition and care. And not from a medical terminology perspective, but from the experience of being with your child every day, and how that perspective is incredibly valuable to a care plan and to being more culturally competent, humble, and responsive. Next slide, please. So when we think about the findings from these parent focus groups, that is what we really took away, this idea of their expertise, this idea of where their role can be more centered in care coordination. Again, we heard this preference around navigation and peer support, as well as the opportunity to better engage with the managed care plan itself, and the reality that to engage community, and in particular to engage parents and families, that then there needs to be the infrastructure of support to make that engagement possible, meaning language access, interpreters. There's got to be childcare if they have children with them, or more flexible scheduling because not everyone can meet at 11 a.m. on a Tuesday. And of course, compensation for that time and that expertise that family members are bringing. And one key takeaway that I think is important to this idea that we are on this constant learning journey is that family engagement is not a one data point, or there's not an end to that family engagement process, but that it is this ongoing process. It's a collaborative process, it's relational, and that it needs to be culturally competent. This idea that it's a continued journey and understanding of who families are and the experiences that they're bringing. Next slide, please. So now we're going to move forward into where do we go from here? Where do we go with this conversation around cultural humility and the ability to create stronger programs? So if we can move to the next slide, and I want to bring us back to this roadmap. And as we consider the work ahead, this idea that there is an opportunity to intervene at different places to make change. And I want to emphasize that this is not to overwhelm us with the work ahead, but more importantly, to create possibility for change, to know that there are multiple points of intervention that enable those opportunities for change. Next slide. So this is something I want to introduce you to, and many of you have likely already seen this. It's from Facilitating Power, but it allows a snapshot of the spectrum of community engagement to community ownership. This opportunity to move in the direction of being more community-centered and led, but also recognizing that not everyone can move to deferring to community ownership at one time, but to check ourselves, again, to do that self-reflection, that organizational reflection, to better understand where we might be along this spectrum as we try to work to become more culturally humble, to become more culturally responsive. So these are resources to help us, again, be in alignment with the values that we're seeking to move forward, and to have these checkpoints that enable us to question, to be curious, and to do better, and to have some tools to help move us in that direction. Next slide, please. And so when we think about what's happening at the federal level, for example, as we move forward in this work, many of you are familiar with the Blueprint for Change that came out a couple of years ago that really sought to move forward these guiding principles for a better system of serving children and youth with special healthcare needs. And I wanted to call attention to it because this is something that's happening at the national level that folks may be aware of, other folks may not. But given the national reach and the conversation that a federal agency is having, there's opportunity to have that surround sound messaging that is critically important to holding, again, health system leaders, managed care plans, and others accountable. These 4 fundamental principles of this blueprint, again, that racism is a social risk factor, that children and youth with special healthcare needs are more severely impacted by these adverse effects, that they require more and different types of services, and that disability is a natural part of the human experience. These fundamental principles are core to what sort of system we want to build. Again, for children and youth with special healthcare needs, and ultimately for everyone. So focusing on improving care for this population will help us improve care for everyone. There's one more slide on this. Next slide. If you could just hit it one more time. Yeah, perfect. So this is their blueprint focus area and vision. I am not a walking advertisement for the federal government, but I do think it's worth highlighting this important call out of the commitment to being more culturally humble, more culturally responsive in the work ahead, because there is a long overdue narrative shift around this conversation. There's a long overdue need to uplift this conversation, again, in every circle, in every opportunity to hone in on the important commitment to cultural humility and cultural responsiveness, again, in order to better respond to the needs of children and youth with special healthcare needs. So it's an important opportunity. It's an important movement to highlight as we seek to make change at the state level, at the local level, and most definitely at the national level. Next slide. So at the state level, there's opportunity to really leverage these statewide reforms. I mentioned to you that our state is going through a number of different changes in order to improve care delivery. This administration, the Newsom administration, has put out multiple efforts to try to strengthen, again, the program. Most recently, one of the strategies that they released was a strategy to support health and opportunity for children and families that would improve Medi-Cal for children and youth with special healthcare needs, for birth equity issues, for all children, right? The 5.5 million plus children that are in Medi-Cal. But also, the population health management, and again, working to go upstream to better understand the community conditions in which children are raised and how Medi-Cal can address that. I'm going to talk about the sub-bullets in just a moment. Also on the accountability side, what are our performance measures that we are placing on managed care plans to tell the impact that they are having? The equity, care coordination, mental health utilization, the outcomes, again, so that we can then hold plans accountable to doing better. Most recently, the Department of Healthcare Services released a health equity roadmap initiative. There are a number of efforts around digital equity in California and creating a stronger broadband infrastructure, as well as more. And so I place these here because it is absolutely essential that we have initiatives that directly relate to cultural competence training or implicit bias training. That's another effort that's moving forward, right? We have required implicit bias trainings, and now there's a bill moving forward to strengthen accountability of that. But not every measure to improve cultural responsiveness is going to have that within the title. The idea that we want to be culturally responsive is that we want to be responsive to the unique needs of children and families. And that's what multiple efforts are doing, and that we need to place that cultural lens on them in order to widen the tent of support for these efforts. So let me talk to you about that. One example is continuous coverage for young children. And that link at the bottom, if you want more information on how to support this effort, is there. But this continuous coverage provision is incredibly important to children and youth with special healthcare needs. A couple of years ago, the state of California implemented a policy that would allow all young children in Medi-Cal from the ages of birth to 5 to stay continuously enrolled in the program. This is an opportunity that was a reality during the public health emergency. No one had to reapply for Medi-Cal during the public health emergency because there was a recognition that we were in an emergency and we didn't want to disrupt the care that families needed. The state of California moved forward that policy for young children, but did so without the funding allocation. This year, we are seeking support for the governor to fund this continuous coverage opportunity. Again, those first few years of life are critical for healthy childhood development. They're critical for identifying developmental delays. They're critical for offering essential screenings and services for children and families to get on the best path for their child. So not having to jump through administrative hoops or try to find the right paperwork, particularly in those first few years of a baby's life, is an incredible opportunity to be responsive to the needs, the diverse needs of our families. And so we're seeking to move that policy provision forward. And again, hope that there is this understanding of how these programs can better respond to the needs of our diverse communities. Because historically, we know that these programs were not set up to support families of color. Historically, these systems were not meant to serve Black and Brown families. But now we are in a position where Black and Brown families can demand better for this program and for their children. And this is one of those opportunities to do just that. A second one is the new CHW benefit. CHW is the shorthand version of community health worker or community health representative or a promotora. There is a new benefit in the Medi-Cal program that would allow community health workers to bill for services. It's an incredible opportunity that offers an economic pipeline for a workforce that is overwhelmingly women of color, oftentimes many from immigrant communities, but offers that very support that we talked about throughout this presentation. The support to help families navigate systems, the support that families want to lean on someone that looks like them, that has their experiences, and that can help them be connected to a system that can serve their child and can do so better because they have an advocate on the inside. So this benefit has now been in place, but I will tell you what is incredibly frustrating is that it hasn't really taken off because you can't just create a new benefit and expect everyone that is doing these services to flock to it when you don't create the infrastructure to welcome them. Many community health workers, many promotoras are part of community organizations that may not be directly affiliated with the healthcare system. So how do you ensure that there is greater connection between those two systems in order to center the needs of children and families? What is the glue to bring them together? What are the training opportunities? What are the funding streams that need to be understood? The billing capacity that needs to be provided to community organizations and so forth. So we want to strengthen how it is that that benefit is implemented, again, to center community experience and wisdom in order to better provide culturally competent, culturally humble care to families. And beyond that, we want to ensure that that benefit adequately pays for these services. Much of these services, much of the work that community health workers and promotoras have done has historically been undervalued, has not been recognized as incredibly impactful when in reality it is, because it is that connection, that navigation that actually enables patient medication adherence or enables families to better understand their care plan in order to have a successful journey for their child. And so we also want to ensure that they're compensated at a rate that truly values this incredible work that community health workers and promotoras are bringing to the healthcare system. So really recognizing that wisdom, making sure that the connections between the systems are functional and that they're compensated at a rate. Next slide, please. And so I want to close with this quote. This is a quote by Dr. Marcela Nunez Smith. She was a senior advisor to the White House COVID-19 response team. I had the privilege of serving on the task force, the Biden-Harris administration COVID-19 task force. And she said, I think we have to push back on an instinct that the fixes are quick. There is not a checkbox where we can say, do these 3 things, but it is a process. And if we can do more in partnership, genuinely with the communities that have been most affected, that's how we begin to establish trustworthiness. I think that quote really captures this conversation and the importance of a lifelong continued commitment to learning and to becoming more culturally humble. And I thank you for being with me as we talk this through together. So next slide. I'd love to open it up to questions and thoughts and reflections from each of you as we continue this work together. I'll also add my contact information at the end to ensure that we stay in community. So thank you so much. And I will open it up to questions and thoughts. And I'll look at the comments that you all have put in too. Oh, so Jessica's bringing, if I scroll up a little bit, this idea of understanding generational trauma with different cultures that need healing. Absolutely. I think generational trauma shows up. It manifests itself in our physical health. To recognize that, to learn that, to appreciate that as a provider is incredibly powerful. Peer support is real. It is that lived experience. There's nothing like that. Can't do cultural competency work without talking to people of the culture. A lack of POC and leadership. Absolutely. I think this idea of those surface level changes, having a diverse workforce that reflects the families we seek to serve, while it's not the end all be all solution, it's absolutely a factor in thinking through how we can become more culturally responsive. Oh, here's a question. How to best address providers who continue to struggle with parents who present as angry, combative, or non-compliant due to oppressive and ACE-related stressors, but aren't bringing humility and the humanity to their work to serve these families. Instead, it shows up as a victim blame mentality and lack of empathy to serve these families. Absolutely. Thank you for raising this point. This idea of shifting the attitude from what's wrong with you to what happened to you. That slight shift in perspective invokes that curiosity that we talked about earlier as we continue to think through how we can learn and grow on this journey. So to your point about providers not bringing humility and humanity to the work, it is that necessary commitment to learn and reflect on curiosity. So that's something that we are working towards at the policy level, as there is greater attention on adverse childhood experiences and ACEs. We were very fortunate to have our first Surgeon General, Nadine Burke-Harris, who really elevated, I think, the conversation around ACEs, and in particular, this idea that brain development happens in those first 5 years of life, the majority of our brain development. And as a result of that, these experiences are long lasting, even when we don't think children are watching or children are experiencing, they are. And I think that greater awareness, I hope, provides this opportunity to present trainings and learning opportunities in a way that is more universal for all providers, rather than pointing the finger at this one or that one, but offering this commitment to learning and growth for all of us as our awareness has shifted around those critical first few years of life and how essential they are to building the lifelong path to healthy adulthood, frankly. Another question, CHWs are a very valuable addition to this work. I wonder, as the intermediaries between families and systems, how they can have the authority to hold services accountable to best serve families when there is a conflict or barrier to access. Absolutely, absolutely. I think part of the advocacy associated with strengthening the community health worker benefit has been, where is the accountability to CHW voice and experience, both in the policymaking process, but then in the implementation process. And I'll be transparent and say, I think that's still undecided, that there is still opportunity to strengthen that advocacy and strengthen that accountability of CHW expertise as leading the way. And I think part of this really does rest in long-standing racist infrastructure of our medical system, where the power dynamic between those with more education versus those with less formal education, and I will say formal education because many of these community leaders are incredibly educated with lived experience, but that power dynamic really does rest in these racist undertones of our traditional medical system, and chipping away at that takes time. And that is what is happening. That's what's been happening these last few decades as the role of community health workers has been elevated in promotoras. And in particular, I think we can look no further than the last few years in the pandemic that really highlighted how essential community leaders, community health workers, community organizations were to ensuring that we were going to make progress through this public health emergency. It was not our medical system alone. It was not our government alone. It required a reliance on community wisdom and community leadership in order to make it through. And so I'm an optimist. I believe in, I really do. I'm an eternal optimist. So I believe that we're slowly sort of shifting this Titanic in order to make that change sustainable. Right, if you could just move to the next slide. I want to make sure folks. So this is just a couple of snapshots of some resources that we've created. We also have a number of additional resources around health coverage, the unwinding for immigrant families. We work very closely with community organizations around dismantling misinformation, like around public charge. A lot of these issues, like I said, are intersectional. So as we seek to create more culturally responsive healthcare systems, that goes hand in hand with educating and empowering our community members to know their rights. And we are your partners in trying to make that happen. So please encourage you to stay in community. Next slide. Here's my contact information. Our website is childrenspartnership.org. We also have a website, allinforhealth.org, that is more geared towards our community partners and offers a number of resources to that effect. Again, we wanted to use this opportunity to create community with you and also to find ways in which we can improve our work, our advocacy for families, for children, because we are in this work together. Your day-to-day work as a parent, your day-to-day work as a provider, all of that is connected. And I want to ensure that we are in community so that we can strengthen our collective work together. So I want to make sure you all know that and believe that and emphasize that as well. And if you are interested in any of the advocacy opportunities, either around the community health worker benefit or the continuous coverage provision, I'll drop the continuous coverage provision. We're seeking to do that over the next couple of weeks. Please do not hesitate to reach out to me. I am your partner, and I'm grateful to have this conversation with you and to be in community with you. And I thank you for the work that you're doing day in and day out to support our young people across the state. So thank you. I'm going to pause, and I'll be here, for 15 more minutes if questions come up. And if you have a question and you want to say it out loud, please raise your hand and we're happy to unmute you. If you don't want to type it in, totally understand that too. Thank you. Thank you. I appreciated the chat. You all were dropping some gems in the chat, so thank you for that. Huge thanks to Melida for
Muchas gracias a Mélida.
Oh, yeah. I think they stopped it, Melida.
Oh, you can hear me now?
Yes, I can hear you now.
Okay. So, thank you very much. It's a pleasure working with both of you. Thank you. So,
And thank you, Mariah.
see, Mariah, is it okay? I need to go to another session. Is it okay if I go, or do you want me to stay a few more minutes?
I think it's okay. I think people are logging off. If someone
Okay.
asks a question in Spanish, I can do my best, Melida.
Okay, I can stay a few more minutes. I'll be right here, and then I'll text you and let you know, because I need to go to another session. Muchas
Absolutely.
gracias.
Gracias. Un placer.
Un placer, señora.
Oh,
Hello.
yes, please. Go ahead.
Thank you for this. This question catches people off guard, but I'm just wondering, as advocates, as a person of color advocating, how do we take away the fear? Sorry, people talking. I'm parked. I swear I'm not moving. Retaliation in advocating is very real, especially in certain parts of California. How do we keep working through this and protecting our kids?
La pregunta de la
So yeah, I mean, how can we protect ourselves? Some of us who, aren't the favorite advocates, or, who speak out loud for our kids. How can we safeguard our children in being safe as we fight for their services?
I really appreciate that question, Jessica. And I don't know if I have a perfect answer for you. I will say a couple things. One is, you're right. There is often risk associated with advocacy, particularly for marginalized communities that have historically been underserved and been, tossed aside. And that retaliation fear is real. So I want to acknowledge that. I want to agree with you. And I want to thank you and other advocates that are standing up for your children. And I will say that I am hopeful that we have made progress in creating the necessary infrastructure to support you in that advocacy. whether it be through a network of organizations that you are affiliated with, such as Family Voices, such as many of the organizations I drew attention to at the beginning. How do we provide you and others with the supportive infrastructure that enables you to feel someone's got your back? And that is through conversations like this. That's through creating community and making connections so that families don't feel alone. So I want to ensure that that infrastructure exists for people, and we just have to make sure that they are connected. And not only for the advocacy pieces, but for our well-being as a whole. Being connected, being in community is essential to our well-being. And again, it gives you that strength, it gives you that safety net, but it also contributes to our overall health. So I want to invite that not only for Family Voices, but for those of us here in this conversation for the Children's Partnership, and also for the many legal entities that we are connected with that also serve a critical role in providing the legal supports necessary in many of those instances if it gets to that place.
Thank you.
Thank you. Mariana, I see your hand is up. Do you have a question?
Yeah, thank you. Can you hear me now?
I can hear you perfectly.
Okay, thank you. Thank you for this great presentation, Mayra. We are talking, we hear about teamwork. So what can you recommend families to also partner, you know, to try to face those challenges? What
Yeah.
can you recommend to the families?
Absolutely. I think, building on the answer from earlier's question with Jessica, I think part of the opportunity for families to be connected and have teams is to create a community amongst each other. And I know Family Voices is incredible at this, as well as the local organizations. But how do we connect families to other families with shared experiences to create that infrastructure of support? And part of that is identifying organizations in your community, but it's also a virtual space now. Somebody mentioned these trainings that people can offer folks to better use technology. There is nothing like the expertise of other families and that peer-to-peer support. So I would encourage that coming together of groups, again, through these formal infrastructures like community organizations, like Family Voices, but also through Facebook and these other opportunities to connect with families going through similar experiences. Because I completely agree with you, Mariana, that power is incredible, and we want to make sure we harness it for the most good.
Thank you.
Thank you. And Vanessa's dropping some ideas in the chat too. Thank you, Vanessa. Okay, Mariah, I think we'll give folks 5 minutes before the closing session. Just want to, again, extend my deepest appreciation to this community of folks that are with us. Muchísimas gracias por estar con nosotros, and really looking forward to continuing to work together to make California stronger for our children and our families. Huge, huge thanks. Muchísimas gracias.